Okay. So my name is Blaise Mapinde, and I'm HISP Rwanda staff who is supporting the implementation of DHIS2, mostly focusing on surveillance and immunization. So today I'll be trying to share a little bit about what has been achieved in leveraging existing solutions of DHIS2, specifically the disease surveillance, in surveilling of MPOX and the response and how it's being used in decision making so that the response can be more effective. So currently, we are supporting the Rwanda Biomedical Center, which is the implementation body within the ministry that is supporting the public health surveillance and emergency preparedness response, which is the division that is in charge of any epidemic or disease surveillance. And currently, they have a national command post that has been set up. This national command post is made up of different partners, stakeholders, also different divisions coming from different disease areas or other programs in an effort to fight or prevent the exposure and the spreading of MPOX. So how it happens is you have the national command post monitoring or handling the 30 districts of Rwanda, which also have small or less bigger command posts, which are monitoring the district hospitals and also the health centers and the community health workers. All the 30 district command posts are directly reporting to the national command post. And then you also have the national reference laboratory that is providing testing and validation of samples to 3 testing sites or sentinel sites. This was as of last month. So currently they're trying to add more testing sites to ensure that all district hospitals have the capability to be able to do that testing. Then you have the aspects on the data management of systems. Here we are coordinating with different partners to ensure that all aspects of the data flow from case detection up to the time the results are available, but also up to the analysis, all systems are working seamlessly. So you have the WellTech application being used for contact tracing, and then you have the LIS or the Laboratory Information System, which is handling all samples received within the lab. And then finally, the Electronic Integrated Disease Surveillance Registry, which is also integrated with the electronic case event-based surveillance. So, yeah. And all those systems are basically monitoring or supporting one stage or one level of this response team or in terms of detection of the diseases. Then you also have contact tracing and home-based care, which is a different team that is reporting directly to the national command post. This is in terms of all positive or confirmed cases that are supposed to be monitored until the final outcome of that particular case. So how is the data flowing and how is the system being supporting at different levels? You have the routine flow, which is what is happening, and then the suspected case, which is detected at the health center or at the community level, is entered in the EIDSR. If it's at the health center, they are entering it directly within the EIDSR, since they have tablets or laptops that they're using. And then when it comes to the community health workers who do not who usually have analog phones, they're using SMS technology. So by sending an SMS, that SMS is directly being sent to the EIDSR, and then the high levels receive a notification that the community health worker has detected and then the health center is supposed to verify or do a sort of triage to confirm this particular case. Once confirmed, then they can move on to the following steps that are supposed to be done once a case has been detected or a suspected case has been detected. So once a sample is collected, that information in terms of lab request, sample processing is entered within EIDSR. And then once the sample reaches the national laboratory or one of the testing sites within that particular area, they are currently re-entering that information within LIS so that they can have the lab request information and the sample details. This is in case if they have collected more than one sample, or if it's a control test of a particular patient. So that information is needed so that we can know who is an initial case or which positives are control positives. Then an Excel is extracted from the laboratory information system, which is then sent to the national command post, who are supposed to both disseminate and also follow up what has been entered in the system for proper dissemination.
Check ladder. Check ladder.
I think somebody's unmuted. Is that on my side?
Yes, she's been muted. Please,
Okay.
let's go ahead.
Thank you. So yeah, the national command post is the one in charge of disseminating the results, which is done through the system of the ADSR. The different facilities are notified, and then the positive cases have to be followed up by the command post, which then goes through the process of contact tracing and also the process of home-based care. So that is how the districts and the command posts are being supported by different systems, starting with the EIDSR through SMS or through user interface, and then going down to using the lab information system, and then finally the contact tracing application that is able to monitor and notify patients where, for example, you have the 21 days of a contact person who is supposed to be monitored. So in the morning, they receive an SMS that is asking them if they have got any symptoms compared to the last contact with the healthcare provider. So if they respond with a yes or no, then if it's a yes, then they will be contacted further so that you can see if they've actually gotten a positive. They might also be able to collect the sample so that they confirm if it's a case. And if it's a no, the patient or possible patient is going to keep on receiving an SMS for the next 21 days until they're out of the suspected group. Then, since the first announcement of the MPOX case in Rwanda, there was a plan to do a 60-day containment exercise. This is basically doing a house-to-house data collection where they're asking a couple of indicators that need to highlight. One, do you have the capability of doing a home-based care? Do you have the capability of washing your hands, or do you even have awareness of what MPOX is about so that you can better respond to it? And obviously, for those that are not aware, they're also performing a kind of an awareness or an education exercise that gives enlightenment on the different population or the different people. This exercise is happening both in the population and then also in the schools, and also at different point of entries to make sure we do not have cases that are lying around without being noticed. So if a person is detected for having suspected or any of the symptoms that might make them a case, they're then sent to the health center. And how this is tracked to know if a person was sent or actually went to the health center is because this data collected is being entered within EIDSR. This is an event-based data collection form that was designed to follow for those particular indicators. So if we know 30 people in a particular health center were sent for testing to confirm whether they have MPOX or not, then the command post is supposed to follow up with the health center if they have received 30 people who have come based off the recommendation of a healthcare provider that visited them from home or from a particular area of group that they were assessing. Then obviously the national command post will perform analysis to look at how the 60-day containment exercise is going. Do we have enough teachers based on how many students we have? Do we have enough schools that are performing assessments based on how much is expected in response or in understanding the disease? And this is all being achieved through DHIS2, as some of the analysis you have seen in the previous presentation from Victoria. So this is a simple sample of how our IDSR reporting form is. The only thing we have actually updated or changed to be able to adapt to the monkeypox response was ensuring that the disease is no longer a part of the public health concerns, but now it's being reported as an individual case. And then obviously, in terms of supporting the 60-day containment, we need to know patients who are received at health facilities, are they just walk-ins, or is it a person who has been sent in an active case search, either from house to house or any assessment. Then obviously you have the sample results part, where we only need to know the results and also the CT values of the particular outcomes. So as I also mentioned, we configured a house-to-house assessment form. This was initially configured for supporting the MPOX house-to-house, but now it has been transitioned to be a simple command post surveillance report, whereby we have also now integrated the MVD aspect, where we are also assessing or looking out for potential cases of MVD in other districts that have not yet made the reports, but might be having contacts in them. So as I mentioned, you have different indicators, schools and readiness in terms of prevention strategies. You have screening among risk groups, which is happening also to make sure the spreading is contained. Then you have point of entries, and then the average or the normal case management, which might include how many positive cases has the facility found. This is in case the individual report is not updated. And then you have become mild cases. That means they might be needing more support, whether it's to transfer them from one facility to the district hospital with more resources, etc. Then as you can see, this a small preview with obviously data omitted for data security purposes, but what you're able to see now is a preview. The command post has these dashboards on their screens, and they're using them in their daily meetings, where they're able to see the standing of the districts for different areas, where you know how many cases have been detected, or how many cases have been confirmed, active case, MPOX active cases. That means they're the ones that have been suspected. And then if, or unfortunately, you get deaths, they're also able to detect them from the national post before being notified. Then also, they have different assessments of trying to understand what are the possible exposures, or which of the exposures have the highest cases for the people that we have been able to detect. So in reality, or in truth, different countries might have different contexts, and you might want to just look at different indicators or particular values within your dashboard. So as long as that data is being collected, whether it's on an individual basis or it's on an aggregate basis, you would be able to populate your dashboard and be able to monitor those particular indicators. So we also have some work that is ongoing. We are not yet complete. There's a lot to be done, though we're thankful for the quick response, both in terms of partners, GIO, in developing the supporting documents. But what now we're trying to work with is different partners who are working with AI detection. So these are cameras that are supposed to be at point of entries. We would like to integrate them with the disease surveillance, so that if there is a case detected, the SMS notification that is integrated in the EIDSR is able to notify the command post to be able to react. And then obviously, as Victoria mentioned, contact tracing has been a very key component in the response, and we're trying to see how we can enhance it, whether through usage of the relationship feature within DHIS2, or working with integrating with other external solutions that might enhance that contact tracing aspect. And then obviously with the existing electronic immunization registry, it has been updated to support data related to vaccine, MPOX, and also for MVD vaccine, which has recently started as of about, I think, yesterday or today. And obviously the EIR, or the electronic immunization registry, also has the digital vaccine card, which is an open portal that just requires the patient or the person to put in their national identification number or phone number, and also the patient ID, and they can generate it depending on whether they have received both MPOX and MVD or MPOX only. And then finally, also in support of MVD, we're using also the existing surveillance system. We have added components for case reporting, also added an aggregate stock management system, because there is a lot of deployment that is ongoing with the National Command Post, and we would like to detect and ensure that each command center is having whatever equipment they require, depending on the number of cases. So having stock data, case data, and also hospital equipment integrated in one dashboard is becoming very useful for the command post in terms of response and also planning when they're having their daily meetings together.